Hello, my name is Nigeria. I'm the respiratory therapist for today, and this is my assistant.
I'm Dominique. I'll be the respiratory surgeon as well today.
And today we will be working with a pneumonia patient who's on a mechanical ventilator. So starting off, I'm going to read the physician order, and it reads as follows. A 52-year-old, 75-kilogram male with a past medical history of hypertension and type 2 diabetes presents to the emergency department with a chief complaint of shortness of breath, chest pain when he breathes or coughs, and fatigue. The patient has had 3 days of worsening dyspnea and productive cough. The patient also notes subjective fevers at home with the highest record temperature of 101.7. On presentation to the emergency department, the patient is noted to be in moderate respiratory distress. The patient is tachypneic with a respiratory rate of 36 breaths per minute, and pulse oximetry is 63% on room air. While doing palpation, egophony and tactile firmities was discovered. There was also a dullness on percussion, and fine crackles was heard bilaterally during auscultation as well. A chest x-ray shows bilateral opacification of the lungs. So a non-breather mask is then placed on the patient at 10 liters and does not improve his oxygen saturation. Despite receiving 30 liters of high-flow nasal cannula oxygen, the patient remains tachypneic and his oxygen saturation only improves to 69%. At this point, the physician determines the patient requires intubation and mechanical ventilation for acute hypoxic respiratory failure. So, first thing first, I'm going to start off intubating, and you need to gather all your supplies and check and make sure that they're in proper use so they won't fail on the patient. So, starting off, I will set up my intubation station where I have 3 ET2 tube sizes, which is 7.5, 7.0, 8.0. I'll be using the 7.5 today because my patient is 75 kilograms. I also have a BMV connected to 100% oxygen. I have a tube holder to secure the tube. I have a closed suctioning, a stylet, a syringe, a Miller blade, and I also have the CO2 detector. So, we will now begin intubation. Prior to intubation, my partner is going to hyperoxygenate the patient at 100% oxygen, and we're going to start intubation in 1, 2, 3. We're going to put the patient in a sniffling position, and I'm going to use my Miller blade. Okay. And I'm going to remove the stylet, and my partner is going to inflate the cuff with 5 cc's. And that's the CO2 detector that determines if we're in the right place. Both lungs are moving, so we know we're correct. And also the CO2 detector is turning yellow.
Okay, so you can put the tube in.
Okay. So we're now gonna secure the tube, and my patient's gonna continue holding the actual ET tube in place. You can wait. Okay. Okay, so the ET tube is secure. Okay, so after intubation, I did connect the closed suctioning to the ET tube because it can also connect to the ventilator as well. And we would need to collect sputum with my pneumonia patient every 4 hours to test the infection. So starting off, I'm going to start off by saying the vital signs were 130 beats per minute, the respiration rate 36, blood pressure was 160/80, and oxygen was 69%. The temperature was 106, and we did collect sputum the first time, and it was a yellowish green color, which does indicate infection. So we also did ABGs, and the pH was 7.12, the PaCO2 was 74, the HDO3 was 26, the PaO2 was 36, and the SaO2 was 7. So with that being said, he does have uncompensated respiratory acidosis with severe hypoxemia. So we will now begin to set up the ventilator. So the mode that we're placing my patient on is assist control volume control. So he will be in AT/VC. My tidal volume is 450, and I already have 450 set. The frequency is 20, so I'm gonna turn that up to 20. And the flow is going to be 55, which is 54. I'm trying to move it. And the FiO2 is going to be at 50%. The PEEP is going to be at 10 because my patient does have pneumonia and the fluid is already in the lungs, so we need to keep the alveolars actually open. That's why our peak will be so high. We're gonna accept all. Okay. So now that we've set, we have our test lungs. So we have our test lungs. Our patient is now ready to be put on a ventilator. So now that we've already tested on the test lung, we're gonna remove it and place it on the ventilator, on the patient. And as you can see, the lungs are moving. Yes. So my mandatory tidal volume is gonna be at 640. The high pressure and the low pressure is gonna be at 185. So after my patient has been on this mode for a few days, we took another ABG report, and the report was the pH 7.45, the PaCO2 42, the HCO3 at 22, and the SaO2 at 80, while the SaO2 was at 96. So the patient is now ready to be weaned for ventilator alarms, and the peak high pressure is 50 centimeters H2O, the frequency high pressure is at 30, the high XL minute ventilation is 12, the low XL minute ventilation is 3.4, the high XL mandatory tidal volume is 640, and the low XL mandatory volume is 225. So I'm then going to my apnea setting, and I'm going to make sure that the seconds are 3 because my frequency is 20, so 60 divided by 20 is 3. And I'm going to make sure the frequency, the tidal volume, and the flow matches what was already. After a couple of days, another ABG was drawn, and the results were pH 7.25, PaCO2 was 55, HCO3 was 22, PaO2 was 76, and SaO2 was 80. The physician decided it would be best for the patient now goes on weaning mode because the ABGs were pretty low. So the weaning process, we're going to first set the ventilator on SIMV, volume control plus pressure support. We're going to make the tidal volume still 450. The flow is going to be at 12. The FiO2 will be set at 30%, and the peak is going to go down to 5. Okay. So after my patient has been on weaning mode for a few hours, the mechanical ventilator setting of the weaning mode was going to be placed on SIMV. Set up. Yes, SIMV, volume control, pressure support. And so we have our tidal volume at 450, the flow at 12, the FiO2 at 30%, and the peak is going to go down to 5. So we're also going to set the apnea alarm, and we're going to set it at 5 because 60 divided by 12 is 5. And the frequency, the tidal volume, and the flow is going to be the exact same as below, and the oxygen at 100. So with the alarms, the high peak is going to be 40, the high frequency is going to be 30, the high VE is 12, and the low VE is 3.40. The high VTE will be 640, and the low VTE is going to be 185. So now, after checking the ABGs again, the weaning process was successful. The underlying cause of ventilatory failure was reversed. There was a presence of inspiratory effort. The patient displayed hemodynamic stability, adequate oxygenation, and acid-base status. The patient was lightly sedated and able to make eye contact. An RSVI was tested, and the results were 90 breaths per minute. The patient was able to tolerate spontaneous breathing trial for up to 30 minutes. I'm going to click manual suction on the ventilator, and I'm going to close suction my patient. Then my partner is going to deflate the cuff. I'm going to disconnect the ventilator and unsecure the tube. We're going to sit the patient in an upright position. And I'm going to instruct for my patient to cough. And once he coughs, I'm just going to slide the ET tube out gently. Then I'm going to place my nasal cannula, my high flow nasal cannula at 2 liters.